in the CAR-PAL study, we first investigated a novel CD19 CAR, and with that, a historic cohort were treated, and we published that in Nature Medicine in 2019. And there we found that the biggest cause of relapse was CD19 negative escape leukemia, and all of those patients passed away as a result of their disease. So we knew that CD19 negative escape was a really huge issue that we really wanted to try hard to overcome. And then at successive iterations of studies at UCL demonstrated that the first approaches weren't necessarily the best. So in the third cohort of CAR-PAL, which we have just finished and I reported on in the Congress, we used a new CD22 CAR T-cell combined with our novel CD19 CAR that's got a lower affinity for CD19 and a fast off rate of binding to CD19, and we sort of put those two together. So we know that if we're targeting CD22 as another antigen, you need a CAR that's really good at sensing antigen at low density levels, because that prevents the leukemia escaping by downregulating CD22. And this was a problem that was found by groups across the world, but including at the NIH, for example. So we were keen to make sure that our CD22 CAR was really sensitive. And so that was one of the specific requirements of the development of that program, which we did in collaboration with our colleagues and collaborators at Autolus. So with that, we've got a really sensitive CD22 CAR, and then we've got our own developed CD19 CAR. We put them together to make AUTO1, which is the sort of dual CAR T product. And then we decided that the best way to investigate it would be to literally mix the two viruses at the point of the transduction process during manufacture. That means that we make this mixed CAR T cell product in the end, but it means that within each patient we can follow all the populations separately and understand more about the biology of what those different populations are doing in terms of disease response, expansion of CAR T cells, and persistence long term. So that's the way that we've approached it. And then so we've reported on this cohort of 14 patients. 11 patients for this cohort. 11 patients were treated, 2 were non-responders. So that left 9 patients who were responding. And then of those 9 responders, we've had 2 relapses. And those have been characterised as being positive for 19 and 22, and a further MRD level relapse, which we then couldn't characterise for antigen level because it fell below the threshold for that sort of detection. So in those 3 patients who've had those events, they were all associated with loss of CAR T cell persistence, which is going to happen in a proportion of patients regardless of study design. So, but what we have demonstrated is that so far the other 6 out of 9 responding patients continue in an MRD negative remission, which is great, and there's been no incidence of antigen negative escape leukemias emerging from that cohort so far. So we were reporting a median follow-up of 8.7 months, and that's obviously quite short. But it is meaningful because CD19 negative relapses happened any time from 3 months in the first cohort. So we would have expected to see something perhaps by now. But obviously longer term follow-up is necessary. But it's exciting because it's the first time that we've demonstrated an effective CD22 CAR. So 3 of the patients treated had had prior CD19 negative disease, and 2 out of 3 of those patients had a complete response. So we know the CD22 CAR is good at getting rid of disease, and now we need to see whether the persistence can be provided in order to provide a platform to see if targeting those 2 antigens is going to actually prevent antigen negative escape. So it's an early report, but it's exciting, and hopefully follow-up reports will be useful to the field to understand how the dual targeting approach works.